Hello, and welcome to Chapter 7. I'm sure you are all exhausted and overwhelmed with all the growth and development and the theorists and their theories of development by now. As we start to move through each section of growth and development from the newborn all the way to the adolescent, I think that you will get a better understanding because you will see it broken down more just for that particular age group versus the theorist telling you everything in a condensed format. While we go through each chapter, I will not go too deep into the psychosexual, cognitive, and psychosocial development as we have spent a lot of time on that in chapter 6. What I will tell you to do is review that information. Please do not skip over it as it is important and it will help tie things together as we move through this course. I cannot stress enough about the importance of growth and development and the impact that it will have not only in your life as a nurse, but on your NCLEX as well. So please do not leave this portion till the last minute because it is a lot of information to take in and to actually understand. And remember, I told you all before that you will have to be able to apply this knowledge to your exams. It will not be concrete comprehension exams, it will be application, analysis, and evaluation. So, with that in mind, we will start with Chapter 7, which focuses on growth and development of the newborn. First, we will discuss extrauterine transition and the physiological development. You want to review your extrauterine transitions. I'm sure this will be just a review as you covered this in maternity, which was just last semester. The biggest thing that you do want to pay attention to is the closing of the ductus arteriosus and how the baby gets oxygen and blood and things of that nature from the mother and how they actually transition. Now, when you get into a hospital setting, and if you are going to work in pediatrics or even mom baby or the nursery, you will see that transition is typically the same for all infants. But you must remember, like I said in previous chapters, that growth and development is unique. This is the same for transition as well. You must look at the hospital policies or your facility's policies and procedures when it comes to extrauterine transition for the infant. Some nurses will transition the infant for 2 hours, whereas some facilities will wait and try to transition the infant for 4 hours. Actual transition may take up to 12 to 16 hours. So you do want to look at that, but do review that section in your book, and we will move on to the physiological development. You want to note that the general appearance, most people think it's just like the babies on the commercials. Please do not be mistaken, especially if you plan to do labor and delivery. You will note that the babies do not come out looking like the babies in the commercials. And most of the time, those are not newborn infants in those commercials, if you didn't already know that. The head of an infant is about 1/4 of the total body size and may appear out of proportion, especially if mom had a vaginal delivery. They see what we call the alien head. Um, there may be disproportionate sizing or what we call molding due to the labor process, and this can even happen with a C-section depending on where the baby was before the section happened. So sometimes the babies have gone down in the delivery canal and they've been stuck down there, and then they go to a section. So because a mom has a section, please, please, please educate her that molding can still occur. You also want to educate these parents that molding is not permanent, so they will not have little alien heads forever. After a long labor, you also want to note that the child may have a caput. This is swelling of the soft tissues of the scalp, and it may extend across the suture lines. Usually, this is evident within 24 hours after birth and usually goes away within a few days. When head trauma occurs during birth, the infant can have what's called a cephalohematoma. This occurs when there is a collection of blood between the skull bone and the periosteum as a result of the ruptured blood vessels. Usually, this can happen with vacuum extractions, or as I stated previously, if the baby got stuck and things of that nature. With a cephalohematoma, this is evident between 24 and 48 hours after birth, and it does not, I repeat, does not cross the suture lines. And on top of that, it may take 2 to 3 weeks to resolve. So you want to take note of the differences between the caput and the cephalohematoma. I know firsthand that that was one of my questions on my NCLEX, whether my baby had a cephalohematoma or a caput. So you do want to know the difference between the two and any nursing interventions that you may need to do. Also, you want to look at educating the parents on what it is and when it will go away and what they need to do. As far as the eyelids, these may be puffy, the abdomen may appear round, the umbilical cord will protrude until the stump falls off. Usually this is in 1 to 3 weeks. You want to teach umbilical cord care. Now, this is another thing that you want to look at within your hospital setting or your facilities to see what kind of care they are now doing for the umbilical cord. I know some studies are now showing that we no longer use alcohol to clean the stump and that the cord will fall off by itself. Some hospitals still do clean the umbilical cord stump with alcohol with each diaper change, and some do not. So you do want to check your hospital policies when it comes to that. You want to note that the infant will remain flexed and the eye color may be indistinguishable. So the baby may have blue eyes at first, and 2 weeks later, the baby may have green eyes, and 2 weeks after that, the baby's eyes may be dark brown. So you want to let mom know that, and dad, because that's usually the first thing they're wanting to know. What color are their eyes? We don't know. Legs, they may appear bowed. Skin is also very delicate, and an infant may have acrocyanosis, which is the bluish discoloration of the hands and the feet. You want to note that your baby should not have central cyanosis. If they have blueness in their chest or their abdomen, that is not okay. Okay? So we want to let parents know this is another part of education. A lot of pediatric, neonatal, and mom baby and all of these specialty areas require a lot of education, especially with the adolescent parents that are now popping up. You want to let them know that the hands and the feet are usually the last place to get blood flow after the baby is born, so this is what causes the bluish discoloration. Tell them that this is normal so they're not freaking out every 5 seconds that their baby's feet are a little blue. If they note any bluish around the lips, the eyes, the chest, the stomach, they should let you know right away. And if the baby is having some kind of heart defects, which we will talk about later on throughout the class, they may be blue all over. So you want to let them know what signs and symptoms to look for. You want to know that the soft spots will be present, and a lot of new parents that have not picked up any kind of literature at all during the months that they were pregnant, they will not want to touch the baby's head at all because they think they're going to puncture these soft spots. You want to let them know that they are not that delicate, but they shouldn't be like poking at them. So teach them not to fear these. The posterior fontanelle usually closes by 3 months, whereas the anterior usually closes by 8 to 18 months. Now we will go through each system. While going through each system, this will be just as if you were doing a newborn assessment from head to toe. During going through each system, I will try to give examples of things that you may see that are either normal or abnormal, and some of the common things that you will look for within your assessment. Of course, this does take time, and as a new nurse, you may miss a few things, especially when doing a newborn assessment, and I will go over those things. First system you want to look at is the neurological system. First, you will note that a Ballard scale assessment is usually done for each infant. This is used in determining the gestational age of the newborn. We will talk more about LGA, SGA, and AGA infants further along in the chapter. They are explained in great detail at the end of your text within this chapter, but we will go over them briefly. Most of the time, the newborn will be in a sleep with short periods of wakefulness between those states. Now, I know if any of you have children and you breastfed, you probably are thinking that your child never slept. That is not true. But what you want to educate the parents on is that the infant will be very sleepy at least the first 24 hours. They will have to wake the infant every 2 to 3 hours to breastfeed. And after that point, the infant will wake up and want to feed more often. If they are bottle feeding, they may stay asleep for at least 4 to 6 hours. We want the parents to bottle feed if they are formula feeding every 3 to 4 hours. What you want to educate parents or guardians about is that breast milk metabolizes very fast. That is why the infant requires frequent feedings. The infant will go through a stage called cluster feeding, especially if the parent is breastfeeding. You want to educate parents about this prior to them delivering so that they understand their infant may not sleep the second night, depending on what time they delivered. The infant may want to eat every 2 hours, the infant may want to eat every hour, or the infant may want to eat every 30 to 45 minutes. This is a normal occurrence, especially with breastfeeding babies. You want to make sure you educate the parents on this because for those that have not picked up any kind of literature, they haven't even Googled anything, they know nothing about breastfeeding, and this comes as a complete surprise to them. And the very common stereotypical response that you will get is that the baby is not getting anything. The baby is getting colostrum. You want to let them know that the infant stimulates mom to make more milk each time the infant breastfeeds. You want to also let them know that each breast contains about a teaspoon and increases to a tablespoon, and that their milk should be in around 3 days. If they have prior kids that they are still breastfeeding, then their milk will come in quite sooner. It may come in a day versus 3 days. For the parents that are having their first child, you do want to let them know that it can be 3 to 5 days before their milk comes in, and they are to breastfeed that colostrum. That is considered liquid gold in the maternity child world. Also, within the neurological system, you want to make sure the infant is awake. The infant may not be awake while you're doing your assessment, but trust me, if you unswaddle the infant, undress them all the way down to the diaper, they most certainly will wake up and start screaming, or they may be alert but quiet. So you do want to check their level of consciousness. It's a little more difficult than it is to do with a child or even an adult, because you know when an adult is not conscious, and it may be kind of hard to tell if an infant is in and out of consciousness because they're asleep. Do not do a sternal rub on these infants, okay? That is not okay. You also want to look at their reflexes. There are 2 or 3 tables in your text that go over the reflexes. You do want to take a look at those. You want to know that they're primitive and the innate behaviors that are seen in the newborn. The 2 most important reflexes that you will hear, or shall I say the 2 most common reflexes that you will hear, the first one is the Babinski reflex. And to elicit this, you can stroke the lateral sole of the newborn's foot from the heel to the ball of the foot to evaluate this type of reflex. The other reflex that is common and that you will hear often is the moral reflex. Now, the thing that you want to note about the moral reflex, and this may or may not be in your text, is that it usually starts to disappear by the time the infant is 3 months of age. So, if you're doing a well child visit on a 5-month-old, they should not still have their moral reflexes. So, within your text, you want to make sure you review the Babinski and the moral reflex in those charts. Now we will move on to the cardiovascular system. Major changes in cardiovascular and respiratory departments after birth. This is considered the extrauterine transition. You want to first make sure that patent ductus arteriosus closes. Now that may take up to 24 hours. So the transition period can range from 2 hours to 24 hours. So you want to keep an eye on your infant if they still have a patent ductus arteriosus. So briefly, what happens in extrauterine transition is the baby comes out, the umbilical cord is clamped, that oxygen and is cut off, and the pressure then changes in the cavity, which causes the closure of the ductus arteriosus. But sometimes that closure does not happen right away. So you do want to do a thorough assessment on your infant during that time. The infant may have a murmur, but as I stated before, if you're not skilled in newborn assessments, you may miss the murmur. And that is normal for new novice nurses within this area. It is easier to hear a murmur on an adult than it is an infant. Because of the speed of their heart rate, it can sometimes be missed by the novice nurse. Also, while listening to the heart and assessing the heart rate, you want to take note if the baby is having episodes of tachycardia. Now, if your baby is screaming to the top of their lungs, of course you expect their heart rate to be elevated. It may be upwards of 180. Try to calm the baby down either with soothies, which is like a sucrose water, a pacifier if the mom allows that, or swaddling and holding the baby. Doing so may calm the baby down, and you can then assess the baby's heart rate. Usually, if the baby is quiet, we want the heart rate to be between 120 and 160. Anything over 160, most physicians and most facilities consider this tachycardia. So we want to take a peek at that and make sure we do a thorough listen. And for the novice nurse, we suggest that you listen for a whole minute. If you're skilled at listening, Then you can listen for 15 seconds. If you're in neonatal resuscitation mode with NRP, then you're only listening for 6 seconds and you're multiplying that by 10. If you're listening for 15 seconds, you're going to multiply that by 4. You want a full minute if you're doing a newborn assessment as a novice nurse. Remember that. You want to note the mediastinal structures, the large abdomen in conjunction with relatively large heart. This reduces the space for lung expansion. Now, should this cause your infant to have respiratory distress? Not so much. But they want to make sure you know how the structures lie within the cavity of an infant versus what we're used to as adults. Their respiratory rate will be between 30 and 60, primarily abdominal and shallow, with irregular depth and rhythm. Short periods of apnea may be seen. If you're in the first stages of transition and the baby is apneic or gasping, they may start neonatal resuscitation. That doesn't necessarily mean they will start CPR or chest compressions. That just means they may give the infant what we call PPV, or positive pressure ventilation. Any of you that have gone through the neonatal resuscitation program, you will know that now they are hooking these infants up to oxygen saturation meters so that we can get a correct O2 sat on the baby, and we're not just giving these infants a lot of oxygen. We actually start them at room air if we are doing the neonatal resuscitation process. So you do want to take note of both their heart rate and respiratory rate. And the same applies with the respiratory rate. If they are screaming to the top of their lungs, you may count 70, 80 breaths. That is not normal. Even if the child is asleep and you still counting 80, 90 breaths, this is not normal. So there may be something going on internally that we cannot see externally. So they may do blood gases and things of that nature on the infant. So also you want to know, as I stated previously, within that first breath, when them coming out of the womb, whether it be a C-section or a vaginal delivery, and they get that first breath of fresh air, their heart rate may be upwards to 180. And if they're really in a deep sleep, their heart rate may go down to about 100, but it should not go below 100, even if they're asleep. If you think the heart rate is too low and you can stimulate the baby and the baby wakes up and is calm and you get a better heart rate, please do another assessment within 15 to 30 minutes just to see how that heart rate is doing. You always want to err on the side of caution when it comes to an infant, because most of their problems are respiratory, rather than with the adult, most of the problems are cardiac. So you do want to pay close attention when it comes to the respiratory rates and the heart rates of an infant. You also want to know when should you notify your physician or your nurse midwife, or notify someone for help. Well, you want to check with your facility and their policies and procedures, because they may have standing orders for your initial assessment, whereas a smaller facility may say call the doctor for anything over 160, regardless of what the infant is doing. Of course, if you have something very irregular, such as your infant's respiratory rate is 15, or even if it's 25 and you see retractions, nasal flaring, and things of that nature, always err on the side of caution and go ahead and call. You would rather call and nothing be wrong than to not call and you have your baby in respiratory distress and no one is there to help. Furthermore, you want to note the sources of heat loss. Remember, there's evaporation, convection, radiation, and conduction. One of the things that you may have seen nurses do, especially in your OB clinicals, is they may put a towel or some kind of drapery or even a warm blanket on the baby scale before weighing the naked infant. This minimizes heat loss via conduction. So you want to look at your text and note the differences between evaporation, convection, radiation, and conduction. While talking about the cardiorespiratory system, this has a lot to do with the infant's vital signs. So you may hear the stress of importance around vital signs, especially if working in the neo ICU or the peds ICU or even mom baby. Depending on the hospital facilities policies, you may be taking vital signs every 2 hours, every 4 hours, depending on the health of the infant. So your infant's temperatures, you want to keep them warm, of course. If they're smaller babies, such as your SGA babies, you may have them double or triple wrapped. They may have to go under a warmer for longer. They may not be able to get a bath for a sustained period of time. Any temperature that is below 97, especially 97.2, 3, 4, any of those, we try to put the baby under the warmer. We try to get the baby warm as quick as possible without overheating the baby. You don't want the baby's temperature to be like 101. Okay, and I'll go over an example of that in a second. You don't want this infant to go through respiratory distress. So, if the infant's temperature continues to be low, they will eventually go into respiratory distress. That is why we stress making sure the respirations are good, the temperature is good, and the heart rate is good. They do have brown fat stores, but those are burned quite easily. So you want to make sure you're keeping that baby warm. So if you are doing an assessment on your infant and you note that the heart rate is 135 and well, let's give you some even numbers if you're multiplying. Let's say your heart rate is 136, your respirations are 66, and your baby seems to be grunting every time they're breathing, and you see their little nostrils flaring out. This is another sign of respiratory distress. So you need to take action when you find things of that nature. Don't just overlook them. And if the parents come to you with any concern that their infant is in any type of respiratory distress, please make sure you note that and that you check the infant thoroughly. Because, like I said earlier, your infants can go into respiratory distress quite easily versus that of adults when it is cardiac related. One other example regarding temperature, heart rate, and respirations is the parents that don't have the education about care of the newborn and they have pillows in the crib, they have the baby in 2 or 3 sets of clothing, hats, socks, mittens, and they have them wrapped in a fleece blanket. And you go in to do your assessment, and baby's temperature is 101. First thing you want to do is get the baby out of all of that stuff. Tell your parents, educate the parents and guardians not to overdress the baby. And sometimes this is a cultural aspect that they do not understand, that they do not have to overdress the baby because they really think the baby's so small and they will get cold easily. Yes, we stress the fact that the baby will get cold, but we don't want the baby to have a heat stroke either. So you want to make sure you educate parents about things of that nature. Here we will start with the gastrointestinal system. You want to note that gastromotility gradually increases during the first years of life. The stomach capacity is about 60 mLs, although please stress to your parents or guardians of these infants that they are not to feed these infants 60 cc's of formula, because what will happen? Vomit will happen and diarrhea usually. But it's usually vomit that happens if they're feeding these kids that much. The first day or so, they usually eat about 20 to 30 cc's or mLs every 3 to 4 hours, and that is with formula. If they're breastfeeding, they're getting about a tablespoon with each feeding, or 2 tablespoons with each feeding. You want to note that the typical emptying time is about 2.5 to 3 hours and increases to 3 to 6 hours during infancy. That is why they have to be fed so often. They may have gastric reflux as a result of diminished lower esophageal sphincter functions and less capable of absorbing fat. They'll receive extra hemoglobin while intrauterine, but they do not need this after birth. Plasma levels of bilirubin then become elevated. Bilirubin can be excreted through the stool, hence why you may have seen the breastfeeding moms, their infants may not poop as much, and by day 2 or 3, their bilirubin is really high. That's because the infant is not excreting enough in the stool, if they're even stooling at all. So the physician may mandate that the mother substitute or supplement with some type of formula along with breastfeeding so that the infant's bilirubin levels can go down. So sometimes the liver is not able to excrete, which causes the excess levels or elevated levels of bilirubin. If excess starts to accumulate, this will cause visible jaundice. Sometimes we have what we call little Chiquita bananas, because that's how yellow they are. If you have a darker skinned infant, you can tell within the yellows of their eyes or even in their hands and feet. So, impaired bilirubin excretion, decreased bilirubin conjugation, and bilirubin overproduction are all causes of jaundice in the newborn. The only thing that is not a cause of jaundice in the newborn would be bilirubin hyperexcretion. That means the infant is pooping a whole lot and they're getting out that excess bilirubin that they had after birth that they did not need. Their bilirubin levels should be assessed within 8 to 12 hours after birth. It's usually obtained with what we call a TC bili or a transcutaneous bili. It's used with a little machine that either goes on their forehead or on their sternum, and it gives us a number. We usually plot that out on a graph, and that tells us how high the baby is or how high risk the baby is. If it is over a certain level, depending on the chart that we use, then a serum bilirubin level is collected, which then we stick the baby's heel and get a serum blood sample to send to the lab. Usually it goes from high or low risk depending on the facility that we use or that you are in. They may have a chart that tells you where it's supposed to be depending on the hours of life. This is all dependent on the hours of life. So, for example, if you have an infant that their bilirubin level is 6, but they are 35 hours of life, this may not be high according to the chart, or it may put them in a medium low risk. Whereas you have an infant that's only 6 hours old and their bilirubin level is 6. That is extremely high. And I just know that from experience. So you have to take into account the hours of age when you are doing these tests. And usually we will do one at the first assessment, which usually happens around 8 to 12 hours, which is accurate. And then we do one after 24 hours. If they continue to trend upwards, the doctor may want you to keep an eye on them a little more closely, like doing them every 8 hours or doing them every 12 hours versus doing once before they go home. If the bilirubin comes back high or elevated to an extent that is too high on the chart that it's plotted on, the doctor will most likely start what we call phototherapy. You may have gotten a chance to see this within your clinicals at Spring Hill. If not, they have a few different types. They have the Billy bed or a Billy blanket that the infant lays on. And then they have double phototherapy and triple phototherapy, which is usually not done in the room. It's usually done in the nursery. If the infant is on phototherapy, jaundice levels via serum or blood should be obtained at least every 8 to 12 hours to assert the effectiveness. If phototherapy is effective, of course, the level should decrease with every blood draw. It should not continue to increase. The newborn's eyes should be protected with an eye shield while under therapy and should be repositioned every 2 hours. And usually these infants will be under the care of the nursery, so the the nursery nurses can keep an eye on them. They're usually in an incubator and they can go ahead and turn them just as if they were an adult patient every 2 hours. They usually are assessing vitals during this time as well. Sometimes this can cause stress for the infant, so they're constantly moving around because when they're on phototherapy, they cannot have on any clothes because they want the light to be directly on their skin. So they only have on a diaper. Now, of course, the incubator is warmed, but the infant is just going through stress because mom's not there. They're not all nice and warm under a blanket. They're stretched out. They have this bright light on them. So it is stressful sometimes for the infant, and you may see them in distress. Not saying they're in respiratory distress, but you may see them crying a lot, and that is why usually it is done in the nursery because the parents can't stand to see the infants cry and squirm, so they want to take them out and they don't put them back in. And then what happens? Of course, we as nurses go to draw the bilirubin levels and they're high. So what usually happens is mom gets discharged and baby's still there as what we call a border baby. And we keep the baby on lights or medications if they're on medications until the levels go down. So, again, this is why we stress the feedings, especially for the first 2 to 3 days while the infant is in the hospital. You want to make sure you educate the parents or guardians on feedings and how the infant excretes bilirubin, what jaundice is, what it looks like, and also that the baby will lose some weight. It is normal for the baby to lose weight after birth. Usually, depending on the facility, most will give a number of about 10%. So anything over 10%, the doctors or midwives will intervene and will want the mom to supplement, especially if they're exclusively breastfeeding. If the baby is losing or has lost more than 10%, You should let the mom know that some of the causes could be that the infant is not voiding and stooling, or they may be voiding and stooling a lot. They may have only colostrum, so there's low calorie counts in that colostrum, or even the absence of the salt and fluid retaining the maternal hormones. So you do want to educate the parents. Even those that have had children, they may know a little, but it never hurts to educate them on things of that nature, especially when it comes to the health of their child. The genital urinary system. The kidneys, they are responsible for regulation of fluid and electrolyte balance, of course, arterial blood pressure, and removal of several toxins. The fetus does not begin urine production until about 9 to 12 weeks of gestation, with renal development continuing until about 36 weeks of gestation. The ability to concentrate urine will not completely be achieved until 3 months. Normal urine output for an infant is usually 15 milliliters per kilogram per day, which equals approximately 2 to 6 voids per day, or we'll tell mom 2 to 6 diapers, wet diapers per day, and this will increase. Urine will usually be low the first day, but like I said, it should increase with intake. Should be examined if there is no void within 24 hours of life. They usually may do a kidney ultrasound, or they will try to straight cath the baby if the baby has not urinated within 24 hours. For males, you want to make sure you're checking the testicles and ensuring there are two there for your testes. The infant may also have a hydrocele, which is a collection of fluid between the parietal and visceral layers of the tunica vaginalis, or the outermost covering of the testes. There's no treatment needed for this unless it persists past a year. It usually corrects itself on its own. As far as the female genitalia is concerned, it depends on the subcutaneous fat and the gestational age. You will certainly see a difference within your preterms versus your full term infants, and this is described on page 102. On page 202 of your text. You also want to know vernix may be present between the labia. This is normal, and you want to educate the parents they do not have to scrub, and that their infants do not have yeast infections soon as they come out of the birth canal. You also want to note that withdrawal of maternal hormones at the time of delivery may result in blood being observed in the diaper. This is called pseudomenstruation. This is also normal and will go away. So you want to educate your parents on this, because they will usually come freaking out saying that the infant has their period if it's a girl, or the baby's bleeding urine, and that's not the case. So please explain that to them, and you may have to reassure them that that is what's going on and that the infant is not bleeding. When you're changing the diaper, it may not even look bright red. It may look like an orange tinged or pink tinged urine in the diaper. Looking at your musculoskeletal, your term newborns will exhibit hypertonic flexion of all extremities. The legs should be assessed first due to flexion development in that area being first. You want to note that muscle tone is not fully developed within the newborn. They cannot fully support the weight of their head. That's why we call them little bobbleheads. The legs should be equal in length, and they should have symmetrical gluteal folds. The base of the spine should also be checked closely for spina bifida. If you do suspect spina bifida, there may be a tuft of hair right above the crease of the buttocks. Also, you want to check for hip dysplasia in these infants. You will do what we call Ortolani's maneuver, in which your newborn should be in a supine position, and you will attempt to abduct the hips 180 degrees while applying upward pressure. If it is a positive result, you will feel clicks, and the infant will not be happy with you. And if you turn the infant over in a prone position and hold them up, you will see that one leg may be shorter than the other. You may also see that their gluteal folds are not accurate or the same. If you are ever unable to abduct either hip when doing Ortolani's maneuver, this is the first thing that you must suspect, and that would be the developmental hip dysplasia. For the males, if they do have a circumcision, you want to educate the parents what to look for. If there's any excess bleeding, you want to note that they need to cover the glans, penis, generously with Vaseline. And some facilities may even cover it with a gauze and Vaseline. You want them to know that the infant may be fussy after the circumcision and not want to eat. This is normal. You still want to make sure that they are offering the infant the breast if they're breastfeeding, or the formula if they are formula feeding. You want to note that if the infant is not eating properly, especially after a circumcision, that this can cause hypoglycemia. The baby may become jittery, irritable, and have a high-pitched cry if they become hypoglycemic. And you will also see this with your gestational diabetic women. Their infants are at risk for hypoglycemia due to the withdrawal of all the glucose that they were getting. So, you want to make sure you are educating. As you can see, I continue to say you must educate, educate, educate. This is a huge part of maternity, newborn nursery, pediatrics, neonatal intensive care, pediatric intensive care, things of that nature. We will always be educating. That is a major part. One other thing I wanted to mention while we're in genitourinary, and I spoke briefly on hypoglycemia. If you do suspect that your infant is hypoglycemic and they are jittery and irritable, please do check the blood sugar or blood glucose level by doing a heel stick. If your infant does come up to be hypoglycemic, and depending on the hospital policy, it may be anything below 40, we want to intervene and do something. Whereas anything between 40 and 60, we're okay with for an infant for the blood glucose level. If they are hypoglycemic, let's say they were 35, what you want to instruct your parents to is to feed the infant. If they're breastfeeding, then they need to be able to put the infant on the breast and breastfeed. If they are formula feeding, the baby needs to eat right then, and then you have to recheck the glucose level. Okay, moving on to musculoskeletal. Newborns exhibit hypertonic sorry, we already talked about musculoskeletal. Let's move on to integumentary system, or the skin. Skin is usually delicate and often mottled, and acrocyanosis may be present. Milia may also be present, which are the small white papules on the nose, face, forehead, and upper torso, caused by plugging of sebaceous glands. It's like a baby form of acne. It will go away. It's okay. You want to educate parents on that. Petechiae, these are a result of the intradermal or submucosal hemorrhage. Small pinpoints, non-raised, perfectly round, reddish purplish spots. Mongolian spots, you will see these. on different cultures, and there are usually darker spots on the buttocks is usually where you will see them. So with your Mongolian spots, these are regularly dark pigmented areas on the posterior lumbar region that are not clinically significant. They can be found in races such as African Americans, Asians, and Native Americans. You want to note the difference between a Mongolian spot and a bruise. It is not the same thing. So if you're doing a assessment on the infant, you want to note that if it is a Mongolian spot, and usually if you're not the first one to do the assessment, someone else should have charted. Therefore, you can verify if it's a Mongolian spot versus a bruise. Infants, we surely hope they don't have bruises on them, especially while they're still in the hospital. But you do want to make sure you verify between either. Next, we have the teleangelic nevi, which are also called capillary hemangiomas, also known as stork bites. These are usually found on the neck and the nose, and they will usually disappear with time. Another thing of the skin that you want to look for is the newborn rash, also known as erythema toxicum. This will appear as red macular with a red macular base with white vesicular center. This also will go away on its own, and you want to let the parents know that this is not contagious. The baby didn't get some deadly Ebola virus or some deadly skin rash that's going to eat them from the inside out. It's nothing of that nature. It will go away. Parents just need a lot of reassurance and education. We will quickly look at the psychosexual, cognitive, and psychosocial development. You do want to read over those sections in your text as they will tie together what we went over in section 6 or chapter 6. You want to know that newborns will be able to imitate facial and manual gestures of adults as early as 12 days. They'll prefer sharply containing colors, large squares, medium bright objects, and ovoid objects with the eyes and a mouth. They will have the ability to respond to auditory stimuli by turning the head and looking with the eyes to find the source. They are also sensitive to touch and handling. They startle very easily, and they can be calmed by therapeutic touch. Nonverbal communication are the initial stages of attachment for a newborn. Caregivers must enhance this attachment. You want to note that newborns also have developmental milestones, especially when it comes to hearing and vision. They are first able to stop activities in response to spoken word. They're then able to turn their heads to locate sound. Then they can locate sounds downward, to and to the side. Then after that, they should be able to locate and turn toward the sound in any direction. And then they should recognize their name or a name when spoken. And they lastly are able to locate sounds made from above. You also want to note with their vision. In the first few hours after birth, newborns do not typically demonstrate a response to visual stimuli. Why is that? Is it that they cannot see right after birth? Think about that. That is not the answer. They can see, but why do they typically not respond? It could be that, hello, they have medication in their eyes after birth. That may sometimes be the reason. I couldn't see with a whole bunch of goo in my eyes either. So Usually they will not respond to visual stimuli until after they get a bath and all of that is wiped off their face and all of that. So you do want to note that. Also, using in stages of development, the infant is in trust versus mistrust. So the infant will rely on others to fulfill their needs and develop basic trust when their caregivers meet these needs. Through supportive, nurturing, and a loving environment, the newborn will form an attachment to the caregiver and develop positive relationships in turn.